Thank you, and I'd like to echo what everyone else has said about thank you so much for inviting me to this conference. It's been a great pleasure. I've made many new friends and hopefully future collaborators. So today I'd like to talk to you about a technology that's new for the treatment of cancer that you may not have actually heard about yet. It's what are called tumor-treating fields. I have no disclosures that are relevant to this talk. And today I'm going to walk you through tumor treating fields, or TTF. We'll talk about the scientific principles, we'll talk about the clinical data, and then what this practically looks like for patients as far as use and toxicity, and a little bit about the future direction where we think actually the mechanism is evolving. If you've never seen a tumor treating device before, this is a tumor treatment field. These are the adhesive pads that are applied to the skin that then connect to this battery that the patients need to carry around for the majority of the day. I'm hopeful I'm going to convince you that this is likely to be a new tool in the treatment of local control in addition to surgery and radiation, that tumor treating fields are looking very promising for several solid malignancies. So where do we use electricity in biological systems? We are using low frequency electricity for stimulating nerves and muscles. We use high frequency electricity for ablative tissues like radiofrequency ablation. And when we talk about tumor treatment fields, we're talking about these alternating electric currents in this intermediate zone, around 100 to 500 kilohertz. What happens when we expose dividing cells to this alternating electricity is, as opposed to a normal dividing cell, and I apologize, my mitotic figures are not nearly as pretty as the tattoos we saw yesterday. This is a very, very precise mechanism where we need this spindle to align perfectly to create daughter cells. However, when we expose this cell to alternating electrical currents, we end up having abnormal microtubule formation, and as opposed to forming additional tumor cells, we end with apoptosis. The logical question is, well, then what happens to non-dividing cells? Are normal tissue going to be at risk with this therapy? And actually, if you have a normal cell that's exposed to this alternating electric current, you do have a little bit of rotation of polar molecules and organelles, but no real biological activity. It's when you end up having the dividing cell that we start to have this differential exposure that leads to actually organelles being driven towards the cleft and microtubules not being able to align as they should in a normal healthy spindle. So these are the two mechanisms that have been proposed. And in culture, we certainly first found that to be true. If you expose cells in culture to this alternating electric current, you see very abnormal mitotic figures that you don't see in control cell populations not exposed to this current. And similarly, we don't see toxicity to normal tissue. We don't see any toxicity to solid organs or hematologic toxicity. So in culture and in the basic science world, this looked very promising. We also interestingly found that different cell types, different tumor cells were susceptible to different frequencies. So melanoma, more susceptible at a frequency of 120 kilohertz, as opposed to glioma, higher frequencies of like 200. And this actually impacts the doses that we're treating patients with. So basic science, reassuring. How did this actually translate into tumors so far? Pretty nicely. We actually now have 3 FDA approved indications for tumor treating fields. And I'm going to go through some of the preliminary data in several other solid malignancies that are currently in phase 3 and registration trials. So let's start with the first clinical trial that proved benefit to tumor treating fields, and that was using TTF as monotherapy. So what a highly aggressive but local disease is glioblastoma. Glioblastoma is the most malignant primary brain tumor. And while we do have a standard of care for the upfront treatment, which we'll go through, there's no clear best agent at the time of recurrence. So this first trial randomized patients in a 2-to-1 fashion between physician's best choice of chemotherapy or tumor treating fields. And as you can see, there was absolutely no difference between tumor treating fields as monotherapy and physician's best choice of chemotherapy, with a first and then more matured evaluation of the intention to treat analysis. So this is what led to the first FDA approved indication. But what I don't think it appropriately reflects is actually a little bit of the more challenging subgroup of patients to treat in this disease. Patients with what are called bevacizumab or Avastin refractory glioblastoma. These are patients that typically have just a few months left because as their tumor has progressed through this therapy, they start to develop significant neurologic impairment. And it's in this really difficult to treat population that actually tumor treating fields shined. We saw improvement in overall survival compared to physicians' best choice in this very difficult to treat population. And also it's important to note that this actually tumor treating fields, whether people were poor performance status or high performance status, didn't really affect the overall survival in this. So the first indication for tumor treating fields didn't actually lead. Oh, and sorry, let me talk a little bit about what this looks like. So for the majority of patients, this is actually stability of disease and not treatment response, but there are people who have radiographic response. It tends to be in quite a delayed fashion. So let me start with the first patient here in the top row. So this is a patient who's at their first recurrence after the standard of care treatment. You can see this large enhancing left frontal mass that 6 months later on tumor treating fields alone decreases in size and less enhancement. And at a year has a remarkable resolving of the enhancing disease. We actually see this sometimes in glioblastoma, and it's always a question of if this was true tumor progression or sorry, I clicked too quickly. True tumor progression, or if this is pseudo-progression. Let me contrast that with the lower row here. So this is a patient who's not at their first recurrence where there's a question, but I didn't even press it at all. But has unfortunately failed Avastin and additional lines of chemotherapy. But even in this patient with this large enhancing left temporal tumor, you can see an improvement at 6 months and significant improvement at 12 months. So this is not the standard, but there are responders, but it's this very delayed response in the order of months to a year. For the rest of the talk, I'm going to talk about tumor treating fields as a combination therapy. And while monotherapy, and I think that data is pretty convincing, it wasn't really well adopted within the neuro-oncology community. But in combination therapy is where it's just data that's breakthrough level. So glioblastoma is a devastating disease without treatment or just surgical treatment, survival of just a few months. The first breakthrough we had was the use of radiation therapy to extend survival. Addition of temozolomide chemotherapy prolonged survival by a couple more months. But actually the addition of tumor treating fields to the standard of care backbone had the most significant improvement in overall survival since radiation. Looking at the phase 3 trial that led to approval of this, we can look at patients who were randomized to temozolomide alone, as opposed to tumor treating fields, had an improvement in progression-free survival, as well as overall survival of almost 4 months. And yet this still didn't lead to adoption of the technology until it read out at the 5-year overall survival data, which was statistically significant more patients alive at 5 years, and it's a figure that we never really thought we could look at glioblastoma. So this is what's led to temozolomide as being an NCCN standard of care for the treatment of glioblastoma. Looking at these patients a little bit more closely, it even adds further validation to the technology because there is a really nice dose response curve. So what do I mean by dose for tumor treating fields? It's how long patients have the device on. So if we look at patients who had low compliance, who didn't wear the device for more than a few hours out of the month, those patients did no better than temozolomide control patients. It's those patients who had high compliance, we're talking about use of more than 20 hours a day, that we see this significant improvement in survival. So further supporting that this device is treating tumor cells and prolonging survival, and ultimately leading to the FDA-approved indications for glioblastoma. The first step towards another solid tumor was actually the FDA's approval of for mesothelioma earlier this year. This was actually based on a single-arm registration trial that showed improvement in survival compared to historic controls. So this is now the next approved indication for tumor treating fields. But there's actually been a lot of other single-arm studies that are showing pretty promising data compared to historic controls. So this is in non-small cell lung cancer patients with locally advanced or stage 4 disease. They had to have failed at least one prior line of chemotherapy, and it was using tumor-treating fields in combination with pemetrexed. And we found, compared to historical controls, a modest improvement in overall survival. And supporting the mechanism, we saw that this was a prolongation of in-field, meaning where the tumor treating fields were being treated. The progression in that area was took longer than out of field for metastatic disease. And this is a bit of an example showing that delay to response. This is a patient who had 5 lesions that were within the tumor treating field. And you can see that for the first several weeks, we don't really see a response. And even as a patient is progressing out of field in multiple areas, it's not until we're at 40 weeks or past the 30-week mark that we start to see a reduction in tumor volume. So these very delayed phases. This promising data has led to a current ongoing phase 3 registration trial for non-small cell lung cancer. And because lung cancer has evolved so quickly, as opposed to being with pemetrexed, this is actually tumor treating fields in combination with either checkpoint inhibition or docetaxel. You're going to kind of see a similar theme through multiple diseases. So in recurrent ovarian cancer, this is another promising single-arm study where we had patients who'd failed multiple lines of chemotherapy, can be as many as 11 prior lines. All of them had to be treated with platinum agents. And so this was using tumor treating fields at a higher frequency than we use for glioblastoma. So at 200 kilohertz, so the same frequency as glioblastoma in combination with paclitaxel. And we saw an improvement in progression-free survival. This data hasn't matured yet for overall survival, but just as a reference, the 1-year overall survival rate was 61%, and that's pretty impressive compared to historical controls for first relapse or fourth relapse. And this is leading to an ongoing phase 3 clinical trial in recurrent ovarian cancer with a combination of paclitaxel. Similarly, for pancreatic cancer, the first trial that was done actually randomized patients between the use of tumor treating fields in combination with gemcitabine or gemcitabine as well as nab-paclitaxel. And the single agent gemcitabine plus tumor treating fields compared to historical controls did have a promising signal, but it's actually in the combination of the 3 agents that was the most impressive prolongation of overall survival, and this is where the current phase 3 trial is for newly diagnosed pancreatic cancer. Some additional trials that I don't have the early data on for yet is the use of tumor treating fields in non-small cell lung cancer brain metastases. This is the METIS trial, as well as the hepatocellular carcinoma trial that's ongoing as a single arm as well. Okay, so I hope I've been able to convince you that tumor treating fields are very promising technology in a variety of solid tumors, but what does this actually look like for the patients? So because this is a local therapy, it looks different depending on the site of disease you're treating. So this is a patient who has arrays for ovarian cancer. This is what the glioblastoma arrays would look like, lung cancer arrays or pancreatic arrays. It's not just applying the arrays and turning on the machine, but this is actually designed to have the dose of the tumor treating fields targeted at the tumor. So the patient ends up, based on imaging, has a treatment plan specifically designed to them to try to deliver the highest dose to the bulk of the tumor. And then patients are actually given a training of where specifically to apply their arrays. They're given this sort of map so they know where to place them each day. And the way it currently works in the United States is there's actually a representative who comes to the home and trains the patients on how they shave their head, how they apply the arrays, how they change the batteries, how they can plug in the batteries and recharge them. And it is very kind of labor intensive for the startup for patients to learn how to use the device, but then once they've been on therapy for a few weeks, it becomes pretty standard for them. And then looking actually at the location of the arrays and what dose of the tumor treating fields this is able to apply gives even further evidence that this is truly a technology that's resulting in improvement in survival. So this is using modeling to see what the different doses for different patients in that upfront glioblastoma trial I referenced before. We can see that the patients who are able to receive a higher dose of the tumor treating fields have a longer survival compared to those patients who have a lower dose based on array placement, further supporting that this is a technology that kills tumor cells and prolongs survival, but not without a cost. So the toxicity profile for this is very different from when we talk about immunotherapy or chemotherapy. The most common toxicity is skin. And that's skin toxicity from both the shaving as well as the arrays. This is an example of a patient with glioblastoma and some lesions around their craniotomy site in the prior radiation field. And then this is a patient who was on treatment for pancreatic with other lesions on their abdomen. So the most common toxicity is skin. And in fact, in the trials, the majority of patients had at least some component of skin toxicity. But as we've moved this into actual clinical practice and are combining tumor treating fields with other agents like bevacizumab, we are seeing even higher rates of toxicity. These are some examples of some pretty significant wounds that are as a result of the tumor treating fields. There is kind of a standard algorithm to use to go by for treating the skin toxicity and monitoring it, but I will tell you from clinical practice, it is incredibly helpful to have a good partnership with a dermatologist because patients can get pretty sick or pretty significant wounds pretty quickly, and they really do need to be closely monitored, and it's helpful to have a clinical partner. The other big toxicity that's talked about with tumor treating fields is the quality of life. So this isn't where patients come in for an infusion or taking an oral medication. This is a device that patients carry with them every day, all day, hopefully for years. And so it's difficult for us to really capture what that impact is on quality of life. But in the clinical trials that are available so far, we don't see any significant difference in quality of life compared to chemotherapy alone arms. And however, you can recognize that this data is confounded by the same variables all of our quality of life data is, that as the further along we go, the less we end up actually having patients complete their surveys. The exception to quality of life being no different is, of course, in the skin toxicity where there is worsened itchy skin as one of the metrics. One of the other things that patients will often talk about, and you can start to see a little bit of a signal with this here, is in the social functioning for quality of life. So these are patients that are going to need to carry around the battery in a pack. They need to plan where they can change their battery or charge their battery. And it is, especially for glioblastoma, a bit of a disclosure of your disease, having the device on your head at all times. The other thing is all clinical trials to date and the FDA, as a result, the FDA approved indications exclude patients who have other sorts of devices like shunts or pacemakers. And as we've needed to treat patients, unfortunately, a lot of brain tumor patients do require shunts. It's important for us to see, is this actually something that has clinical significance? And so far, it looks reassuring that having these implanted devices while being an exclusion doesn't actually impact patients in any significant manner. This is a nice study done by my colleagues up in San Francisco who looked at adjustable shunt settings with the starting of tumor treating fields and found no change in shunt settings. There have been several reports, and we've treated several patients with shunts as well as pacemakers, and no significant changes in any of their settings. The way practically we tend to do this is we have patients monitored either by their cardiologist or neurosurgeon before they start the device, and then afterwards to make sure that there's no change in any of their implanted devices. And then the other toxicity that's very real with this treatment is the financial toxicity. So current cost is around $21,000 a month in the United States, as well as in Europe. And that's led to several countries not approving the therapy for their patients because it doesn't meet sort of their threshold for, while we're talking about an improvement in overall survival of 4 months, that ends up being a pretty significant cost. At this time, tumor treating fields are used predominantly in the United States and a few European countries, Japan, and then the device was developed in Israel, so in Israel as well. My understanding is it's going to become available here, and this is going to be a very real issue to talk about with patients. And then lastly, I talked a bit about the preliminary mechanism of action being the effects of microtubules and movements of organelles. But actually, as we're seeing the benefits really in that combination therapy, it's opening our eyes to maybe there's other mechanisms that this is working by as well. So these are my colleagues when I was at Stanford looking at the effects of tumor treatment fields on cell membrane permeability. So in cell culture, we are able to find, yes, we do have the expected and previously documented effect on microtubules, but actually tumor treatment fields affect membrane permeability as well, so that we can have different markers enter the cells. And the assumption is other chemotherapies having more penetration as well. Part of the way that this permeability works is actually these formation of holes, and specifically in tumor cells that we don't see in normal cells. These are some nice pictographs of microscopy, demonstrating these holes that lead to that permeability. So this is what we are suspecting to be an additional mechanism of benefit for tumor treating fields. I mentioned that the ongoing non-small cell lung cancer trial is using immunotherapy, and not too surprisingly, we also see in culture that combination of immunotherapy plus tumor treating fields looks to be an increased benefit over either therapy alone. And so this is being studied in several small studies in other diseases, and lung cancer being the largest space that we're investigating this at this time. So in summary, I hope I've been able to convince you that exposing dividing cells to alternating electric current disrupts microtubule formation, as well as movement of charged organelles and macromolecules. Clinically, when we talk about treatment with alternating electric fields, that's called tumor treating fields. That this is a pretty promising technology for several types of local treatment for solid tumors. The main toxicity is skin and financial, and that we're just now starting to expand our knowledge of the mechanism beyond the initial proposal. So I want to thank you so much for your attention, and I welcome any questions.